the pleasure of having Dr. Shahzad Khan talk about the public health implications of COVID-19. Most or all of the attendings today are probably familiar with our format. It's going to be a 1 hour long webinar. The first 20 to 30 minutes will be spent through a formal talk by Dr. Shahzad Khan, after which we will have a panel discussion discussing a lot of the questions that have already been posed through the WhatsApp group, and then also additional questions that attendees from today are welcome to add into the Q&A section of your Zoom window. So without further ado, Dr. Shahzad Khan, please go right ahead. Thank you.
Okay, thank you, Waleed. There was a chat about the volume. I hope it's better now. Waleed, can you verify? Is it
Yes,
okay?
please continue. It's okay.
Okay. Assalamu alaikum. Good evening from Islamabad. I think it's good morning in US and many of the other outside Pakistan. Um, Initially, I'll give you a little bit of background about what is happening in Pakistan. You know, the numbers are all over. We have around 140,000 cases already sort of identified. Many would be without any test, so there will be much more than this number actually. More than 2,500, 2,600 deaths have been sort of registered. The same applies to them because of the fact that the testing was initially low. So we couldn't test much of the people initially who were getting the disease, and especially when they had comorbidities. So in cases of comorbidities, mostly people died because of the add-on complications, maybe of corona. But actually the label given to them was this, whatever their primary cause was. So far, we can say that there is now I can see there is now a clear recognition of the issue with the government as well as with the people. 2 weeks ago, the people, population, and common men and women, they were talking about a lot of stuff regarding the conspiracy theories and a lot of saying that it's not that serious. There were many people who were not accepting the fact that it will be a very serious problem. This is something which was triggered by some of the comments from different high-level officials, including politicians and others, and a lot of international messages coming through WhatsApp and social media, other social media. But now, as far as we can see in Rawalpindi, Islamabad region, every other household has got at least 1 or 2 cases of COVID. So all of my family members, accomplices, friends, colleagues, all of them almost know somebody who has got a COVID patient. This was not the case, say, two weeks ago, or at least not a month ago. So the thing is that it has spread at a very fast pace for Pakistan. The initial 50,000 cases took around 3 months, 87, 86, 87 days. So we reached from 0 to 50,000 in maybe 3 months, but we reached from 50,000 to 100,000 in 7 days. So that was too fast a speed for any spread of infection. Something like you can see that the same signal was given by a lot of private sector hospitals when they erected the boards saying we are full, we are not accepting any patient of corona. So there were some in Karachi, some in Lahore, and then in Islamabad, some of the pictures roaming around. So people came to know that there are now no hospital beds. There is a big issue in Pakistan of availability of beds. And then I started having calls from different colleagues of reference in different big hospitals in Pakistan. Because of my student base, because of my, say, 27, 28 years service in this area, they thought maybe I could help get them a bed. Then I realized that this is a problem in which people have now started suffering more. It's not just the fear of disease; it's the treatment shortcomings, as well as a lot of issues which revolve around this issue. To brief you about a little bit, because the topic of today is living with COVID. So why I chose this topic? Because I have seen some of my colleagues. I have seen, and I'm talking to you from a COVID house. I'm upstairs in a separate room, but my wife, Dr. Tabinda, she got positive, got symptoms on 28th of May. I also had a little bit of symptoms, fever and slight cough. We both got tested on 29th May, and her result was COVID positive. Mine was COVID negative. Maybe it was a false negative because the similar symptoms were almost the same. So she was isolated. She came upstairs and she had high-grade fever, severe myalgia, body aches, cough with sputum. So all typical symptoms of COVID, which are textbook symptom since the day one when the COVID was diagnosed. They were supposed to be a high-grade fever with body aches, myalgia, and severe cough with breathlessness. So she was isolated, and we immediately started Panadol and one antibiotic, azithromycin, and anti-allergic, vitamin D, vitamin C, whatever the most of the consultants, most of the consultants were recommending these kind of medications. And we were lucky that she got her symptoms improved within 2 days. So I am actually telling you my own sort of information with living with a COVID case, and also myself, because I was also diagnosed having COVID positive on 9th of June. Although I had very little symptom, and my symptoms were also relieved like Dr. Tabinda's symptoms. So this was something which we had both contracted, and she actually got tested negative after 14 days. Her two tests became negative. Mine is awaited. Hopefully, inshallah, I'll also be tested negative, but symptoms are much less than they were initially. So from the COVID house, and from people who are in contact with me about this disease, there are some observations from Pakistan, and then we can discuss. It will not be a one-sided thing. All of you can contribute your comments, because we have 1 hour. Let's say 30 minutes. I'll take 30 minutes, and then we will give time to all of our panelists and all of our colleagues who are online. The thing is that there is something which is very common nowadays, is a lot of people with minimal symptoms. So in my family, in my colleagues, in my friends, there is one extreme of cases. There is one extreme of cases who have almost very little symptom, like even no fever, just a little bit of sore throat, just a little bit of body aches, and that's it. The other extreme is that people, they get diagnosed, and within 2 days they end up with a severe breathlessness, chest discomfort, and they end up in a hospital, and they are put on ventilators. So I have no idea how this disease progresses in different sort of individuals. Within the same family, we have people with very less symptoms, very sort of inconspicuous symptoms, and others having very severe symptoms of respiratory distress syndrome. And there is another thing which we have seen for the last 1 month, which is a very common symptom, which was with me as well as Tabinda. It was severe diarrhea. So the severe gastroenteritis is one additional, which was already mentioned, that it can cause diarrhea. But nowadays in Pakistani cases, we are witnessing a lot of gastric problems in the cases of corona. I had it, and I had to use a lot of medication for sort of herbal, or you can say sabgol and yogurt and desi jo totke hote hain, wo sare try kiye, and I got better. My diarrhea didn't complicate much, and it made me weak, but and it was I think that was the worst symptom which I had for my corona. Tabinda had cough and high-grade fever and myalgia. My family members, some of them, they had got COVID, and they have body aches and fever and cough. So one thing which is very common in this country is the presentation complaint is very diverse. People have different complaints. There is no typical case. Only a few have a typical symptoms of corona, and they end up going for testing and they get positive. On the other side, there are some very typical cases of COVID with fever, with cough, is big patches on the lungs on X-rays and tested negative consecutively. So I have seen some of my friends who were tested more than 3 or 4 times repeatedly for within the period of 1 week, and they didn't get a positive PCR test for corona, but their half of the lung on one side was collapsed and there were patches on the other side, on the both second on the other lung. They had fever, they had cough, and they had all the symptoms of. So that also complicates a problem of corona, because in many of the peripheral areas of Pakistan, you will not get an X-ray done. You will not get a good GP who will auscultate and get your pneumonia diagnosed from your chest, and you will be given a small sort of a medication, and the lung may become more more damaged in the time being. Something which is also strange is that there are a lot of asymptomatic cases. I have been in touch with NIH, and I haven't been in touch with a lot of people who are doing seroprevalence studies. People have told me that there are a lot of cases in Pakistan who are asymptomatic, and they were just accidentally, they were supposed to be going for with somebody else, and they got them tested themselves, and the corona was positive. So there were extreme of situations over here. On one side, you have asymptomatic cases with the tested positive. On the other side, you have very febrile pneumonic patches and very high grade fever and cough cases with PCR negative. And in between, there is a mix of symptoms which are happening around the country. Like I mentioned, the acceptance is here now. So people do accept that this is a disease, and the fear of disease is actually more than the disease itself. So we are more afraid of getting the disease, and this has created a lot of anxiety. So what I see is another big wave of anxiety and mental health issues. I saw, it was good to see Professor Rizwan Taj with us in this webinar. There are a lot of mental health issues which are emerging. We already have a very high burden of common mental disorders in Pakistan, very high burden of anxiety, depression, and mental retardation in the children, and in adults. There is depression and anxiety. This disease has, I think, at least it has doubled the common mental issues of Pakistanis. Access to care, you can see. It's my personal opinion. I will not. I cannot sort of verify this by numbers, but my personal opinion is based on a lot of people who came across with the health system. So the more interaction you have with the healthcare delivery system, with the tertiary care hospital, there are chances that you will get a more complicated disease. I don't know how we can prove this, but for the last 3 months, I've been following people, those who stayed at home, those who took good remedy, good diet, nutrition, Panadol, antibiotics, on teleconsultation. They discussed something like by, you can say, by telephone or by just staying positive and keeping positive and staying at home. They were better off than those who were taken or they went to the hospital on foot. They walked to the hospital. They insisted on being admitted over there, say a few 2 weeks ago, 3 weeks ago, when there were beds available. They kept on moving back to hospitals again and again. They got more complications. So more interaction you have with a high risk facility like a tertiary care, the chances of your disease getting worse disease, I think this is something which I am building on. Definitely it has to be substantiated by some data. It is just an anecdotal evidence. This is just an evidence of my colleagues and my other friends and family members telling me about the different cases. So the issue is that there are a huge number of cases in Pakistan, and I will definitely multiply them by at least 10 to make a number of total cases in Pakistan, because of the fact that we have tested very less. So if there are 100,000, 150,000, so maybe 1.5 million cases would be there in Pakistan. There was a study in Punjab where they attributed around 600,000 cases in Lahore only. That was based on some estimation based on sampling. Majority of the cases, around 85 to 86%, are asymptomatic or minimal symptoms. Around 10%, from 85 to 95%, about 10%, they have moderate symptoms like high-grade fever, severe body aches, cough, chest infections, and around 5% have very serious complications like unconsciousness and severe diarrhea and dehydration and respiratory distress syndrome. So this is something which is going on over here. We have increased testing. It's around 30,000 tests per day. 30,000 tests per day is still very less than the required number, which was around 1 month ago. We were supposed to be doing 50,000 tests per day, but we are still half the way after 1 month. The number of testing should be at least maybe 80 or 90,000 by now. The openness of different shopping areas and other free movement of people, it is also there. There is almost unrestricted movement to anywhere, and that also is making a big problem of carrying the virus to different one place to other places. Similarly, there are some issues with the availability of space inside the hospital. That is another issue. And then there is another unchecked, unregulated private sector profiteering and hoarding that has also emerged as a big public health issue in this country. People charging up to in millions from the cases. You can compare the Pakistani rupee into dollar rate. So they are charging almost hospital beds or per day room charges into US dollars, thousands of dollars per day. That is another thing which was coming up in different sort of news. My suggestion and my own experience, which I had been through, like I told you, my wife, she got it and then she got recovered and now she's back to normal routine. I myself got it and then I felt much better, and I'm still feeling much better. I hope that it will resolve without much complications. Two of my kids, they have the disease, maybe because it was in the family, so they also got it. They also are least symptomatic. Hopefully, they will also go through this phase of whatever this 10 days or 12 days period is. Most of the time, I have seen is that being optimistic, being good in your nutrition, being good in your thoughts, in your ideas, thinking positively, not thinking about only the downsides and the negative things. Don't sort of waste yourself in too much of unnecessary discussions and online identification of treatments and trying those treatments on yourself. There are some herbal as well as some allopathic treatments, but none of them, so far, I don't think any of them has proven to be effective. There is no treatment at present. I don't think there is any golden drug or any gold standard treatment protocol which can affect everybody. Different drugs affect different people. But one thing which I have seen is the early you respond to, the early you recognize the issue, the early you isolate yourself and start taking care of yourself, like good diet, rest, and anti-inflammatories. So as soon as possible, you take anti-allergic and anti-inflammatory drugs. I think the immune response definitely doesn't go to that level which may create problems for you. For us, for all of us, like 4 or 5 cases within my home, what we did was we immediately started Panadol, although the fever was less, but still because of its anti-inflammatory, it's not just for people think that it's only for the fever, but I think it is more than just antipyretic. It is an anti-inflammatory drug which has worked globally. So we took paracetamol and then added, because of the fever and chest infection, added antibiotic. And although it's a sort of antiviral, it's a viral disease, but I have seen antibiotics working in almost all the cases. So for my own known family members of 10 plus, all of them, when we started antibiotics, they felt within 2 days, they felt much better. Myself, my wife, my kids, all of them had felt better with Panadol and a good antibiotic. Azithromycin is one, but there can be many others. None of them in my family have tried any antiviral or any other different kind of treatments which are being circulated. This is something which is common for us. The issue is that there are so many other things which are parallel in this country moving around. So we have a very high burden of heart disease. It's around 25% adults in Pakistan, they are hypertensive. So 1 in 4 is supposed to be having hypertension. Around 12 to 13% have diabetes. Around 9%, the recent survey showed, hepatitis C. There is a very high prevalence of malnutrition. There is a very high prevalence of anxiety and depression. So coupled with all those cases, this alone, this corona is not that much of a very high prevalence to make a huge mortality. But given that we have such a huge comorbidities, the estimates which are coming up for maybe July and August, they are also taking into consideration the comorbidities. So maybe corona alone may not be that much fatal, that much lethal, but in a country where every 4th or 3rd or 5th person is either diabetic or hypertensive or mental health and other issues, corona will definitely affect them very badly. So we have to be very clear about one thing, that we should be trying to prevent as much as possible. And if we get it, we should act immediately and as soon as possible. So Waleed, if you have anybody else to talk to, I think I'll stop, and if there are some questions, some comments, we can discuss those.
That's great, Dr. Shahzad Khan. This is Majid Shafiq. Thank you very much for such a wonderful overview. And I think one thing that I really found useful from your discussion, your talk, was sort of the personal and professional references that you made as well, which really sort of drives home the point that COVID, it's a pandemic. It is neither absent from Pakistan, nor is it something that is a conspiracy hatched exclusively against Pakistan. This is unfortunately a worldwide tragedy that is unfolding in different countries at their own pace for a variety of reasons, right? It doesn't infect everybody in the same at the same speed. Obviously, in a country like the U.S. That is massively interlinked through interstate highways and very heavy domestic travel, it's conceivable, it's understandable that the pace of the peak was so much quicker, and now in Pakistan we're seeing some of that as well. So we have an excellent panel here, and I have some questions that the audience has asked as well. Some of them have been asked through the Q&A over here, and then we've also had some questions previously submitted through the WhatsApp group as well.
Okay.
I think one of the general themes that I see here, which is a very, very important theme here, knowing so many personal examples of people who are struggling to find any beds in Pakistan currently, whether they be ventilator beds, ICU beds, or simply regular beds. I think a major theme that comes up is what to do with as far as home-based management is concerned. So one of the questions that some people have asked is, what's the best antipyretic? Should we use something like Panadol or should we use ibuprofen? And yeah, I think related to that is another question somebody asked, and I'm going to quote: if someone gets over the body aches and still has a temperature of 99 Celsius throughout the day, should they be advised to continue Panadol? Come what may. So maybe if Dr. Shahzad, you can answer
Okay.
those first, and then I'll have others
Yeah.
chime in if they want to.
Okay, just my own experience. I think the need for bed should be linked with the need for oxygen and need for severe respiratory distress. Just lying around on a bed inside a hospital will make things worse, not only for the person himself or herself, but also for the family. So you will be exposing yourself into a much higher viral load as well as many other infectious agents, plus exposing your family. So I don't think, and I think I mentioned it in my introduction, that I have seen people who have had a more interaction with the hospital, getting serious on a very high rate, high speed, as compared to those who didn't go near a hospital and they went for a home care. If you want to do home care, I think for a high literate or literate family, it is very easy to get hold of a pulse oximeter, thermometer, or thermogun, whatever you may call it. We had I purchased a gun which was showing the temperature on just one click. And it was good because we cross-checked it with the thermometer, the normal traditional thermometer. So the calibration was okay. So get hold of a pulse oximeter, get hold of a thermogun or a good thermometer, blood pressure apparatus. So you wait for at least maybe as much as you can, unless you have a difficulty in breathing. Fever is no issue. Fever is supposed to be there. Myalgia will be there, very severe myalgia, and people I have seen my family members crying with pain because of myalgia, and they thought somebody is beating them on the muscles and the back. Diarrhea is very frequent, so you have to do a symptomatic treatment. So antipyretic, I will still recommend paracetamol 2-3 times a day, for at least 5 days. Even if the temperature is 99, do take paracetamol. I said it is not just for antipyretic effect, it is the anti-inflammatory response which NSAIDs have. Similarly, I personally used anti-allergic as well. I used Mytica for some allergic because I have some allergies with different. I'm allergic to different dust and different pollens, and this is a season as well. So people can also use some anti-allergics. You can also use some of the sort of drugs which can help you in your breathing, like mucolator, the mucus thinning. You can call them the medicine which makes mucus thin, and it is easy to excrete out of your sputum and cough. It makes breathing easy. So at home, you need good antibiotic, you need Panadol, you need pulse oximeter, you need thermometer, you need blood pressure apparatus, and you need a separate room, or at least a room where no one else should be coming. Make it separate, one bed, and then good food, which is very important. People forget about the food. Small, frequent meals repeatedly. We did that, and we didn't suffer much of the bloating and gastric effect. So small, frequent meals, high protein diet. Definitely add meat or pulses or beans in any of the day thing. Take at least 2 eggs per day, minimum of 2 eggs. You can have three, two in the morning and one in the evening. But
Thank you,
eggs,
Dr. Shahzad.
yeah,
Great.
this is something.
Okay, well, thank you. That's helpful. And I know Dr. Awais Masood is also, among our panelists
Okay.
who is going to chime in over here as well. And I'll just make a quick clarification for everybody as well. So the acetaminophen, so Panadol is acetaminophen, which is, an antipyretic. But then so many other antipyretics, as Dr. Shahzad was alluding to, are anti-inflammatories as well. Those are your NSAIDs. So those would include things like Brufen and
Yeah, and they
such.
have allowed it. They have allowed Brufen now. They say it can be used. I saw that the one reference. Although they initially they banned, they said Brufen. I think it was coming from some French researchers that brufen should not be given, and we made an announcement in Pakistan that no one should take brufen. But then now they are saying that ibuprofen can be taken.
Right. So just realize, just like Dr. Shahzad, very nicely alluded to, we don't have any, robust evidence that any of these, works. So
Yes.
the cornerstone of management is really, rest, take care of your diet, take care of your sleep, take care of your hydration, try to avoid interacting with other people to limit the spread of disease even as you're at home. And things like Panadol can help with the muscle aches, they can help with the fever. And if you're looking for something that helps with the pain and fever but also helps with an anti-inflammatory effect, although it hasn't been proven yet, then you might look for something like ibuprofen, which comes as brufen in Pakistan. And there was some controversy over that earlier on, like Dr. Shahzad said, but as of right now, there's no evidence that that hurts us in any way. So Dr. Masood, go right ahead, please.
Thank you very much. As Masood, I'm in New Jersey here. Just one comment about antibiotics use in COVID. I mean, our experience is different. People in Pakistan, their experience is different. So, but I have seen that in Pakistan, I have been and contributing to treatment of many patients there. Actually, all of my friends and they are doctors. I have seen the trend that they are taking very heavy and very broad-spectrum antibiotics, and almost all of them has no indication to taking antibiotics. I mean, secondary infection is common, and it's important to prevent that also. And if they take some antibiotics for that, that's fine. But if you have no indication, should not be taking like 3 or 4. Even I've seen antibiotics different at the same time. I can tell you that right now I'm seeing about 9 or 10 patients in Pakistan, I mean, talking to them, and none of them have indication for any broad spectrum antibiotics. And they are taking meropenem, levofloxacin, Emson, linezolid also at the same time. I have done check with their procalcitonin level is like negative. And they have been prescribed by I'm talking about in Punjab, not in Northwest area. So that thing need to avoid. I mean, there are some indication for antibiotics. You can take some like narrow spectrum antibiotics. That is fine if there's some suspicions for any other infection. But I have seen that many complications because of those antibiotics, not from the COVID virus. So just my comment on that.
Thank you. That's extremely helpful. A related question to, and I would second that too. By the way, hearing from so many people who are getting all kinds of antibiotics, which can then increase your risk for Clostridium difficile infection, a potentially deadly infection of the GI tract, among other things. It can breed resistance of other organisms and such as well. Another question that some of the people have asked is, people are now recognizing the importance of having a pulse oximeter available, and Dr. Shahzad already mentioned that in his talk, that really that's sort of the most important reason for somebody to look to go to the hospital is if your oxygen levels are low, because we know COVID pneumonia affects through hypoxic respiratory failure. It can lead to ARDS and such. And the first thing that you will see if you're really deteriorating in the majority of cases is hypoxia. So people are now recognizing, trying to purchase pulse oximeters and such, and many people have it. And a question I frequently get asked as well is, what level of oxygen to try to provide supplemental oxygen therapy with at home, and or at what level should they look to go to the hospital. So would any of the panelists like to take that question? Dr. Shahzad, would you like to comment on that first?
Yes, actually this is something which is one of the biggest challenges when you have some respiratory problems. Pulse oximeter is useful in I think this COVID would be one of the best scenario where the pulse oximeter will help. Otherwise, in many of the other diseases, because I did my clinical in Mayo Hospital in Lahore and in my medical years, and still when I was administration in administration in the hospital, I saw a lot of typical symptoms which even don't need an investigation. But this disease is so strange that from inside your lung is absolutely patchy, and there are so many pneumonic patches in your lung, and you do not have much symptoms. Yesterday, we met 2 or 3 of such kind of patients who were there for some other antenatal checkup or something, and they were asked to go for an ultrasound and a chest X-ray for cesarean or whatever the routine anesthesia clearance takes. And they had big patches in their lungs without any symptoms. It is very rare that you have such a high chance of pneumonia or pneumonic patches, viral pneumonia in your lung, and you don't have that much of symptoms. So pulse oximeter helps when your oxygen saturation or your capacity to get the blood oxygenated is decreasing. So we were told, Mubin, one of my class fellow, and he's a trained pulmonologist from US, came back to Shifa and now is with another hospital in Islamabad. He told me that you have to check to keep the figure of 94%. So if it is going below 94%, you should rush to the hospital. Many are saying 85% or 90%, but within a few minutes, within maybe 1 or 2 hours, a person can lose this oxygen saturation because of a lot of problems in their lungs and very fast expansion of those patches. So this will help a lot. It was very highly, it became very costly, but I think new shipment have arrived and it's now available at less price. So to me, I will still recommend in home care, not only just to have a pulse oximeter, but also there are some concentrators of oxygen and some oxygen cylinders. People even have got hold of a disposable or mobile oxygen cylinders so that in case they need it for 1 or 2 days, they can use it. So people are trying a lot of things, but I don't think that when you are needing oxygen or when you are having severe breathlessness, you should not stay at home. Then it is very essential that you go to emergency.
Great. And Dr. Aves, you have raised hand as well. Please go right ahead.
I agree with Dr. Shahzad. I mean, but obviously, our colleagues in Pakistan, they know the reality better over there than us here. I mean, obviously, then before they go to hospital, they have to be planning ahead of time that if things deteriorates, which hospital they would go, what facility they carry, and if they have they carry all the facilities they required there, obviously then they should plan a bit earlier. If they don't have those facilities, it's better to stay home as much as they can. 94 or even lower oxygen level, if they can maintain that at home, is better. But again, this all depends on the realities and what the facilities over there are, what the facilities available in the hospital is available. I am involved in a patient, some of them, they have lower oxygen saturation than 94, even close to 90, and they were able to stay home and they did okay. But again, this condition can deteriorate very quickly, and I totally agree with Dr. Shahzad. He knows realities over there better. I think I would go for his opinion.
Yeah. And Majid, there is one more thing which is quite in the news nowadays in Pakistan is this plasma replacement. It is so much in, I can call it like a simple SOP. Everybody who got an admission for COVID in any hospital has started asking the doctors to give plasma. And in many cases, even the doctors are asking arrange plasma if he becomes deteriorated. So they started by just getting the patient inside the hospital. They start looking for the plasma donors who have been. And to tell you very frankly, majority of the people who have been treated, or we cannot say cured, in a convalescence period after maybe 20 days or 25 days, when we got their antibody tested, they didn't have any antibody for corona. So very few people who had sort of they got the disease They were COVID positive, they turned COVID negative, 2 negative tests, and then maybe waiting for another 1 week. They got antibody tested. And I think yesterday we tested 6 of those such people. All of them had no antibody. My wife, she got, after she got herself tested the antibody after 2 weeks of the first symptom, and she didn't have any antibody. So the combo test was supposed to be above 1 and her was 0.3. So there was some, so there is a big issue. The people who are getting treatment, they are actually being treated for plasma, but many of the people who have been, who have the disease, who are now in convalescence period or they have recovered, not all of them have antibodies. So that is another issue. That is another business which is now booming in the private sector. People have started charging money for donation of plasma. Look at this, that you were dying, you were having one of the worst disease in the world. God gave you another life. And after that you say, I will take maybe 1 million or 1.5 million for my 1 bottle of plasma. And if we get that blood tested for antibody, there is no antibody. So that is another issue.
You know, it's a very good point that you raised. Thank you very much, Dr. Shahzad. And it's you know, all of these things are, when you don't have robust evidence in favor of or against any therapy, and you're dealing with a disease that is surrounded by a little bit of either actual or perceived novelty, then that is a very scary situation, because that's where evidence-based medicine can get thrown out the window so quickly. And in fact, even within the past 3 months, we have seen how, you know, time after time again, people have tried one thing or another without evidence, out of desperation. Whereas even if you just, you know, even if you just look at the data, the reality is that the majority of people who will undergo this infection will self-resolve, right? Their bodies will, you know, will take care of the infection. Obviously, a substantial minority will get really sick, but it's very important to pair the patient's clinical condition with need for therapy. And experimental therapy, of course, comes at the very end of anybody's algorithm. Plasma-based therapy, of course, is one of them. Dr. Shahzad, you mentioned how people are really going after, you know, plasma donors. One of the things that comes to my mind as I look at that is simultaneously the concern that, as we've seen and, you know, read in reports and such too, and experienced personally as physicians, so many of these people are at higher risk for thromboembolic events, right? They can develop clots. And so clearly, these people have a milieu that is more thrombogenic. You know, one of the hypotheses that comes to mind is it even worthwhile adding more of the same kind of plasma? Would that lead to potentially an even higher propensity for blood clotting? One of the many questions to answer. One of the many reasons why lack of evidence-based medicine is so fraught with risk. Dr. Awais Masood, would you like to add to that? And then after that, Dr. Farhan Qadir will. Thank you.
I think Dr. Shahzad raised a very, I think the most important, I mean, concern at this point, having the same thing, and I wish things will get better and people actually will test antibodies before, I mean, accepting any the plasma. The other thing which I'd like to mention, maybe a separate topic, but I just mentioned that I have seen many people who are getting, access to tocilizumab. Many of them don't need it, and some of people who need it, they're not able to get it. That's another big, I think, a problem in Pakistan.
Thank you very much. Excellent point there. Don't try to hoard medications that you don't require. Yeah, go ahead.
Majid, there is just one comment. I'm part of one of the study, because this is plasma is being given for an experimental basis. It has not been proven as a treatment of now. So I will not be sharing the results, but so far what is the general observation in Pakistan is it hasn't saved anybody on ventilator. So the people who are running for this plasma, most of their patients are on ventilators. So if there is a clear-cut evidence that out of 300 plus plasma donations in this country, none of the patient on the ventilator was saved by a plasma, I don't think that even the doctors should be making people or making attendants so much conscious about getting hold of a plasma. It may work on moderate disease. I don't know how, maybe because there are some antibodies available to fight with the disease. But it hasn't worked. And there are some very specific guidelines, even in that experiment. There is a very specific inclusion criteria for putting the patient on plasma. And they are and they are all about mild to moderate case. So it is not recommended even for the serious cases. So I think this webinar should make people clarify that it is not the end stage like a transplant or like a cancer therapy or like something which has been, I don't see it has been, yeah, it hasn't been proven to be effective in very serious cases. This is I think confirmed from all sources. I called almost all the centers and I asked, and they say no, sorry, this is not helping in people on vent. So then definitely there is something else which can be done, even if it is not that much of value. Then why to spend so much money for nothing?
Thank
And
you
it's
very
still,
much.
yeah,
Excellent
yeah.
point. Dr. Farhan Qadir, would you like to add more to this discussion? I see the raised hand. Mr. Walid, if you could unmute him, please. Dr. Farhan Qadir, thank you.
Ji, Assalamu alaikum. I think I had discussion with a lot of my Pakistani colleagues. Um, One thing I recommended them when they were talking to me is to provide good critical care based on my own personal experience. Um, I don't think so that this disease is way too off or different, though we all like to try different medication, including plasma, tocilizumab. I think it's very important to provide good critical care. In terms of a lot of patients who actually end up staying home, I've been recommending them self-proning, which is harmless in a lot of aspects. And also one thing is that there is no role of antibiotic unless someone is infected. I think it's all about evidence-based practice. Um, Based on my understanding regarding convalescent plasma, there is only one good paper, and that also is not peer-reviewed yet. I don't really want to comment on it, which shows pretty much the same kind of results like remdesivir. Patients are on oxygen, mild to moderate disease. So my request to my Pakistani colleagues back home and also some of my friends and when I talk to is to provide good critical care, and hopefully that will save more life than these medications, which are cheaper and better care. Hopefully that will help. Thank you.
Dr. Farhan, thank you very much for making that comment. I definitely would echo that. Right. I think the example that I like to always share with friends and colleagues is the fact that quality improvement is an actual science in the best of centers. And what is quality improvement? It is simply efforts to translate uh, known to be proven therapies into actual bedside practice. Even in the best of centers across the world, we human beings struggle to implement findings from robust, evidence, robust scientific studies, and the basic, the name of the game is really good critical care. Just like Dr. Farhan Kadir said there, the reality is that the majority of patients will be able to ride out this infection. They will get sick and then they will get better. Some of them will get sick enough to the point that their oxygen levels might become life threatening for a certain period of time. For those people, we provide them with oxygen and let their body get more time to do the same as it does in the majority of cases. And for even smaller numbers of patients, their respiratory failure will get so severe that they will actually require ventilator management. And when you get to that point where you're trying to assist somebody with their breathing, we know from good evidence accumulated over the past several decades that ventilators can cause as much harm as they can provide benefit. And so the name of the game then becomes what we call lung protective ventilation, what we refer to as keeping the patients dry, not overloading them with drips and infusions of IV fluids, with giving them a chance to get off of the ventilator every day whenever clinically feasible, and so on. So those are all the basics of good critical care. And the reality is that critical care is a tool that we have in the 21st century to let bodies get more time to recover. Other than that, we're basically not doing much of anything at this point in time. Like Dr. Shahzad and others mentioned as well, we currently don't have a robustly proven therapy that's going to alter the course of the disease in any patient. Perhaps remdesivir may have some data that favors its use, but it's not widely available, not yet, not even in the United States right now. So short of that, monitor your oxygen levels, try to do whatever you can at home to keep them up. And like Dr. Farhan Kadir mentioned too, self-proning, awake proning is something that you could use. Just try to lie down with your belly to the bed. I pasted a link to a website conveniently called covidprotocols.org. I pasted it in the chat forum. And that's I know of it because I've been involved in constantly rehashing it. This is a document that at my institution the attendings and the fellows from different specialties have put together, and every week we meet twice a week to examine more and more evidence as it comes in and add to this this living document. So don't print it out, but refer to it every day or every week, and see where the evidence is at present. But the name of the game is really good critical care. I do want to ask our panelists a couple more questions. People have talked about sort of, and this is a topic that comes up frequently, is about gaining immunity and such, right? So what does the panel think? We understand at present as far as are we going to become immune after we have recovered? And a related question to that is, if a doctor or another healthcare provider becomes COVID positive, how long should they take before they return to work? Dr. Shahzad, would you like to take that?
Yeah, there is in Pakistan we had an SOP initially for say 2 weeks. Then we revised it, and now in what we are doing is when you have COVID and you have passed 10 days after being tested positive or the start of the symptom, and you are free for at least 3 days from the symptoms like fever, cough, and breathlessness and myalgia. If you are free for 3 days, and if you have completed 7 days, so almost around 10 days, people get better and they can break their isolation. Initially, there was a compulsion of getting 2 PCR test negatives, but I think that, now it's not being practiced. So if you are you passed 10 days, you are 3 days free from symptoms, and you had a positive test around 10 days ago, you can go and you don't need a testing. Immunity, if you talk about immunity, for the last 1 month, I've been following with a lot of my UK friends as well. They sent me a link today. Even in the UK, the persons having immunity after getting COVID is not more than 20%. So that is a very strange thing. So immune response, maybe it's a good thing. For example, I didn't have any antibody in myself for the last maybe 2 weeks. I am suffering. The Tabinda didn't get any antibody. Maybe it was not a good, robust immune response which saved us or had less symptoms. Maybe a very high level response by the body against the virus makes persons more symptomatic. I don't know. This is all being researched. The more symptoms you have, and I have found one of my students who was in Multan, he sent me a report of a very high quality lab, Aga Khan, and he had a very high level of antibodies in his blood where he didn't get even the disease. His family members were positive. He was working in a hospital with the COVID patients. He never got the disease, repeatedly tested negative, and antibody level was around 6 point something, where it was needed was only above 1. So this is something which is quite common in Pakistan. Nothing is sure about it. But the only worry which comes when we say the immunity in the persons is less, and we should have good diet and we should do exercise, mental health sort of exercises like breathing exercises and positive thinking. Physical activity also promotes mental health. So all of these we recommend. But the immunity thing, it worries me is that we can have, maybe it can come back again. But then again, it's like flu. It doesn't come in the same month. It may be coming after a few months. So that is one issue. I have with us, I think I have seen Professor Rizwan Taj. I would request him to show some light on, or to advise some of the people on how to improve their mental health, specifically in this time of severe terror and a lot of threatening situation in the country. Majid, over to you.
Excellent idea, Dr. Rizwan Taj. Are you with us? I don't see him here, though. Maybe he's part of the attendees. Mr. Walid, can you check?
I saw him in the
I think he is left now.
Okay, great.
Maybe, yeah.
Our team
Okay.
can contribute to that.
Yeah, anyone on mental health, please.
Waqar, are you there?
Kindly, might be good to get to Professor Iqbal Afridi. He's the president of Pakistan Psychiatric Society.
Yeah, sure.
If we can give the mic to Professor Iqbal Afridi.
Mr. Walid, if you could unmute him, please. Thank you. Professor Afridi, go ahead. You're muted right now.
Yeah, he's muted.
Hello.
Please go right ahead, please.
Yeah.
Hello.
Yeah, we can hear you.
Can't hear.
Yeah, Professor Iqbal.
Afridi, go right ahead, Professor Iqbal Afridi. We can hear you if you could comment on psych.
Okay. I'm really grateful to all of you, especially the participants and those who are contributing to the academic of Pakistan. And I'm very thankful to all of them. And this is their great contribution, because nowadays the pandemic of COVID has reached everywhere, and we want that there should be some coordination, collaboration, so that we can have that treatment which is really evidence-based. And there are many rumors and other things which we face, and misconception, myths in Pakistan. So therefore, our colleagues who are working in the established department are abroad, so their valuable opinion will definitely give us a chance to make our treatment line and preventive and other measures according to the international standard. Thank you very much.
Thank you very much for the excellent your comments, Professor Iqbal Afridi. We are at the top of the hour, and we have covered a lot of items, but I do want to get a couple of things more additionally done. One, I want to take one more subject matter. Then I'll let any other panelist comment if they feel like they wanted to comment something on any aspect of today's discussion or anything else. And then if we have time, we will take one live question as well. So the subject to be discussed here is the role of thromboprophylaxis in COVID, or antithrombotic management. People have asked about that. Would anyone like to comment on that? Dr. Shahzad, would you like to start?
In Pakistan, they are recommending. They are almost every person who is tested positive is started with Loprin or Disprin CV, or there is another oral tablet by the name of Accept or something like this. There is a trend of giving the platelet sort of desegregation, degrade drugs. This has not been proven by any study so far in Pakistan that it has effect or not. But given the Italian autopsy data and a lot of thrombotic and thromboembolic and other presentations in a global scenario, people have started giving these medications, but I'm not sure whether they helped or not.
So I will, piggyback on that as well, and I will say, at my institution in Boston as well, we do use it because of the data that we have seen associating COVID with increased risk of blood clots. Somebody asked about Clexane in particular, which is enoxaparin, and it is one of our favorite drugs to be used. We do try to pair it with sort of the severity of illness as indicated by where the patient is currently situated. If they're on the hospital floor, we usually give prophylactic doses. So for example, enoxaparin once a day. And if they are in the ICU, we try to do it a little bit more. We've all seen strokes. We've seen arterial lines get thrombosed. Of course, we've seen DVTs and PEs as well. The data is still fluid. Like Dr. Shahzad said, it needs to be emphasized, but so we have tried to, at our institution, as in many other places, tried to do, as honest of a job as we can with using them. I would again draw your attention to, doing these kinds of things in a protocolized manner. One of the many options available to everyone would be just go to covidprotocols.org and look at the section on hematology to help you figure out, whether to use it, and if so, what doses and what specific indications. That is by no means the
Majid, in Pakistan, what they are doing is they are getting the D-dimer done, C-reactive protein, and ferritin. These three levels, they get it done. If they are above 1,000, they start Clexane. So yes, the heparin substitutes, they are also being used in the admitted cases. I was referring to the home-based cases in Pakistan. They are being advised Disprin, CV, or Loprin, or any other different kind of blood thinning. Otherwise, Clexane is being given in Pakistan also in ICUs in cases where the D-dimers and ferritin and C-reactive protein, these are higher.
Ji, bilkul. And here in the US too, there's such variation. Many centers are using those kinds of pro-inflammatory markers and D-dimers as well, and others aren't. It's really because the evidence is sort of still fluid. We're struggling. Dr. Awais Masood has a comment to make in this regard as well. Please go right ahead.
So here's my experience while not treating outside. Contributing to their care in some patient in Pakistan. So basically, patient who is not patient, a person who is asymptomatic doesn't need anything, not even aspirin. But again, a patient who are sick or symptomatic, we in our hospital also, hospitalized patient, their dose of levofloxacin, not levofloxacin, Lovenox, it depends upon their D-dimer, their marker level. So if it's very high, they need a higher dose, and they're like less, then they just need like 40 milligram daily. If they're like in about range of 2000, they need 40 twice a day. And if it's more than that, they need a full therapeutic dose.
Excellent, thank you. So if any other member of the panel would like to add anything, and if you are going to, I would also invite you to see if you can cover this final question on what face masks should health professionals use. Would anyone who hasn't had a chance to speak yet like to add anything to today's discussion?
Majid, this is Dr. Nahid Usmani. Can I add a few comments?
Please go right ahead, Dr. Usmani.
Okay. So first of all healthcare professional and everybody should have a simple surgical mask that they wear at all times while in the hospital. That is the policy that is implemented across United States and Europe. I don't think you need KN95 or N95 masks other than when you are in direct proximity of a COVID-19 patient that you're taking care of. Other than that, a simple surgical mask is all that is required 24/7. Secondly, my recommendation to people in Pakistan and to physicians in Pakistan is to develop national standards. This is a new disease. Nobody knows what the right thing to do is. But if you develop national standards, classify the disease as mild, moderate, severe, and what to do in each of those categories, which is standardized across, then you will be successful and you will have clear data. Like Majid was explaining, that they're updating the COVID protocols on a weekly to daily basis. You will be able to amend based on real time data, and it will be, clinically sound and scientifically verified. But it all depends whether there is any data gathering on these patients. I found this whole discussion extremely useful. Thank you, Dr. Shahzad, both for sharing your personal experiences and the clinical experiences.
Yeah.
So that's what I would like to add in on my behalf. Thank you.
Thank you very much for adding, those insightful comments, Dr. Osmani. Excellent. Thank you to attendees and the panelists for continuing to stick around. I know we are a little bit over time. I will, take one live question as well, and of course, anybody who needs to jump off is welcome to. So I'm going to ask Dr. Hamama Bushra to see if she could ask her question if it hasn't been answered yet. Go ahead. You are currently muted.
Hello, can you hear me, please?
Yes.
Okay. I'm Professor Umar from Rawalpindi Medical University. So thank you very much.
Assalamualaikum Umar साहब, क्या हाल है? ठीक हैं, Dr. Shahzad? Thank you for joining.
तो ठीक है, मैं देख रहा था शहजाद को भी और वह. So thank you very much. मैं काफी देर से I was just listening, and I think that is a wonderful discussion. और इस वक्त जो situation है पाकिस्तान में, we are the second in Punjab and possibly fifth in the whole country. The Rawalpindi is the, I think, second epicenter in Punjab. We have about 2,000 positive cases and have about 220 mortality, which is, I think, 2.2%. And we have about 10% critical cases. If I just quote today, we have 400, I think, 10 cases. Out of them, 240 are on oxygen. Out of this, hundreds are on 10-liter oxygen, and there are about 30 on ventilators. So this is a huge burden. Well, just precisely, I think we have three issues. जो हमारा challenge है इस वक्त healthcare delivery system पे, वो ये है कि how to reduce the burden. So this is the major question. As everybody is saying that the number is going to increase, burden is going to increase, and we all understand our health system is very weak. So how to reduce? So this is the challenge to the government and the healthcare worker and to the general population. And that we all know is because that's only possible with the prevention and intervention. Second is the how to do the capacity buildings. So possibly I would like to know the experience of globally, that how they dealt with this, and particularly in our setup, which is we have less beds, we have less ICU beds, less high dependency beds, and less human resources, and more infection in the healthcare work, reducing the workforce. This is the second issue. And third, obviously, people do not believe in evidence-based medicine or rational use of medicine. At the same time, attendants are very worried of the outcomes. And many physicians, even from our center, they use the drug like, tulisumab, plasma, convalescent plasma, remdesivir, ivermectin, and, and they're not used in proper doses. I do understand what Avas was saying. So I think these are the three major challenges for us. So I think I would like to have your short comment and guidance that how to face this challenge in this particular scenario. Thank you very much for asking me for my.
Thank you. Majid, may I answer?
Ji, bilkul. Absolutely. Okay. Go ahead.
I think this is very pertinent points, all very sort of relevant things mentioned by Professor Umar, and he's in the field. He's fighting at the forefront of Rawalpindi region. All the big districts surrounding Rawalpindi are also coming to Rawalpindi for COVID management. And Rawalpindi Institute is also one of the institutes who is working on, who is part of the experimental studies. He didn't mention it, but I know that they are part of the big plasma study also. So they are part of a lot of other clinical trials. They are doing a lot of research. They are doing a lot of capacity building training, prevention and control. The internationally known phenomenon, the nationally known practice is lockdown. WHO already advised intermittent lockdown for Pakistan. I think we have to go for some of this practice specifically in those areas which are hotspots. And in Islamabad, they did that. They closed some of the sectors where there were a lot of cases coming. So in Pakistan, I think the first and the most important understanding which the government and the policymakers should do is understanding that we cannot bear the burden. Like Professor Umar already mentioned, they are already doing over their capacity. So we cannot wait for another few weeks to get people on the streets. There will be fights and there will be riots over here on beds. So the first thing we should be doing is, you may call it smart lockdown, but please, you have to go for a lockdown in the cases, in areas where there are more cases. In this digital world, everybody knows through the cell number that which areas have, and we have apps. We have a lot of apps showing people who have tested positive, their cell numbers are with the government, with NADRA. So it's not difficult to map the areas with high load and make them maybe 10 days or 15 days lockdown over there. It will definitely help. Capacity building, Professor Umar mentioned. I will share one of the link. It is on the website of Health Services Academy. We have started with CPSP, with WHO, and with Chinese University of Hong Kong. We have started intensive care management, first level, high level intensive care management training, PPE use and disposal, and donning, coughing, and different kind of ventilator use trainings online. It is 3 days online and then 1 day in the hospital. It is free. It gives a certification by CPSP plus WHO plus Chinese University plus HSA. So it's a very much value added training. I would request everybody to go at healthservicesacademy.edu.pk. Just put see over there COVID basic trainings, and you will find the link. Register yourself, and our volunteer will definitely reach to you and register you and give you online training. There are some softwares there through which you can use different types of ventilators, ICU settings. There are a lot of course material available to you. There will be reading material given to you free of cost. So training and capacity building, I don't see there is a big issue. In fact, there is another side. People are worried. Professor Umar is right in getting their doctors trained. But on the other side, the doctors working in RIU or RMC or Holy Family or BDHQ, they are worried that if they got training in ICU, they will spend the rest of their year in ICU. So they are reluctant to get the training. That is one of our big problem for us. So if Dr. Umar can convince their young doctors, the newcomers who should be trained, and they would become the forerunner and front runner of sort of an intensive care management. You don't have that much ICUs, but a trained person would be very much beneficial even in the wards. You can turn the wards into good critical care. I think from the first sentence, Majid and Shahid and everybody is talking about, Zahid is talking about this intensive care or good critical care. It doesn't necessarily need to be state-of-art ICU. It has to be a very, very well-trained HR and the medication, of course. So the second is capacity building. We will be helping, and I'll make sure, because I am the focal person for those trainings. You can directly contact me. We have a huge number of seats for that. We have one of the top critical specialists in Pakistan, like Professor Janal Aslam, Professor Shahab Naqvi. These are some of the Professor Taki from Lahore, and there are Madiha Hashmi from Karachi. So we are working with the senior people in Pakistan, and they are willing to work with us to impart these trainings. So this second one is training, and third one is, of course, the media and mass media and making people aware of how to behave and how to. And people have started, I think now I see a change because of a lot of political people as well as famous celebrities and personalities getting COVID. Unfortunately, now people have started believing what the doctors were saying around 3 months ago. Thank you,
Thank
Majid.
you so much. Thank you very much. So real quick, Dr. Waqar Azim, and then Dr. Awais Masood, and then we'll end.
So thank you so much for giving me the opportunity. This is Waqar Azim. Just two quick comments. As most of the people know, in Pakistan, I'm a psychiatrist and involved in a lot of things in Pakistan. Just two quick things. I think it's extremely important how we take care of our frontline staff mentally and physically. If they're in good morale, we will produce good results. If we have demoralized workforce, no matter whatever we put together, it's not going to work. And second comment is that a lot of questions were asked about anxiety and depression and mental health. We are doing a series of webinars on these particular topics. So there will be a next one on this topic for 90 minutes on June 28th. Thank you.
Thank you, sir.
Thank you so much. And Dr. Masood, go ahead.
Yeah, I'll be brief. So I'm an intensivist and also a nephrologist. Here in over last almost 3 months, we have seen that there are so many renal issues in ICU patient also. And the way we started doing hemodialysis on those patients, initially we did a lot of mistakes, and then we learned, and then we actually changed our doing how to dialyze the patient in ICU and other renal stuff. So then we share our knowledge with other institutes in US, and they actually adapted it. So my question from Dr. Shahzad and Dr. Omar is that if we can contribute to our experience with the nephrologist in your institute or area, please let me know. There are many critical and very different issues other than regular take care of dialysis patient or renal patient in ICU. I'll be more than happy to share with them.
Thank you, Dr. Masood. And if you want, you could also share your email address for Dr. Shahzad through the private sort of chat link as well. Great. And Dr. Waqar Azim, did you have any other comment? I see the raised hand. Perhaps it was by mistake. Well, thank you very much to everybody for a lively and a very fruitful webinar. It was wonderful learning from everyone and hearing from everyone. Special thanks to Dr. Shahzad for sharing your perspectives and experiences and helping so many of the questions get answered. Please stay safe, everybody, and thank you for all that you do in taking care of humanity. This too shall pass, inshallah. Thank you. Khudafis.
Thank you, man.